Dr. Hadania, I think, we've just gone through all of the data on biologics, particularly seeing all kind of the new exciting data in COPD. And, I think you've had a lot of experience using biologics in asthma. And I think I wanted to hear from you kind of, how you think through in asthma, kind of which drug you're using and how you're thinking about how you might apply that in kind of as we see a changing landscape in COPD, how you may apply that to COPD.
Thank you for the question, Stephanie. And I agree, it's an exciting time that we have all these opportunities. We've dealt with asthma now. We have six biologics approved in that field in the United States. And in COPD, things are moving. We have only one. But our experience in asthma with biologic has taught us a lot about patient selection. So it's obviously these two diseases are different. They're inflammation in asthma and COPD, as we talked about, may be different as well. The use of biomarkers may help us identify which biologic to choose. And that has been very, very helpful in asthma. We look at biomarkers, we look at whether the patient has comorbidities. Certainly, some biologics in asthma are approved for more than one condition other than asthma, and often these conditions coexist with asthma. Certainly, we're dealing with different type of population, and probably the cutoff of biomarkers, especially when it comes to blood eosinophil, may be different. You've researched COPD for a long time. You understand that maybe the role of eosinophils in asthma and COPD may be different. It's an important biomarker, but maybe the cutoff should be different, and this is based on the clinical trials that you've outlined. So, but I think the fact that what we learned in asthma is we put the patient first, and actually discussing with the patient, doing shared decision making when you choose a biologic, especially if there's more than one choice for a biologic, is important. Obviously, there's lots of hoops that we have to jump over to get these approved. As you know, with the prior authorization, patients' cost out of pocket is all these things we've learned a lot in asthma will certainly come for COPD. And probably it's a bit of a challenge, I think, in the COPD population. In fact, I wanted to ask you that now we have one biologic approved for COPD. Where do you see this going in the future, and why do you think the COPD population is a bit more challenging than the asthma population when it comes to biologic, or do you?
No, I mean, I think that's a really good question. And I think you're right in that, we certainly have those really kind of difficult to treat asthma patients too. Almost some of them almost kind of look more like COPD, right? Even though maybe they were never a smoker. And so some of that might be that you really do have more mixed inflammation in COPD, where we do really have patients who maybe have less type 2 inflammation, where you have a lot more type 2 inflammation in asthma, where we're really targeting that. So I think that's one thing. And that means that maybe some of our biologics that are targeting kind of hopefully targeting more broadly than just type 2 inflammation. I think there is some hope that maybe the anti-IL-33s are targeting more broadly, and certainly anti-TSLPs, although we're seeing that that's even in COPD in the phase twos are, working better in the type 2 high population or the eosinophil high population. And I do think the other kind of major issue with the COPD patient population is a lot of them, they're older. There's certainly, I mean, we see this in asthma too, but all of them have fixed defects and have fixed disease that they're not going to get some of that back. And oftentimes, this developed somewhat insidiously. So they've got deconditioning, so you've got a lot of, and then have other comorbidities like cardiovascular disease, depression, obstructive sleep apnea. And so I think you've got issues with maybe that we need more broad inflammatory targeting, at least in some patients, or different types. And so I'm hopeful that as we talked about for the asthma patient populations, that we may have different endotypes that we can target with our different patient populations or our different biologics. But I think then there's also, the issue of our what can we make better versus what can't we make better, and making sure that we're kind of thinking through those things with our patients, and certainly doing using biologics in conjunction with our other kind of non medical therapies like pulmonary rehabilitation, or just exercise in general, making sure that we're getting our comorbidities treated so that we're actually kind of treating that whole patient, as you were saying, putting that patient first, because there's a lot of things we're not going to just treat with the biologics. I don't know how you've been have you been thinking about it in the same kind of way, or what are you
Yeah, yeah,
thinking?
yeah. No, all these are important. There's opportunities with new treatments for COPD, but there are challenges. Can't claim that it's all smooth riding because, the population we're dealing with is certainly much more comorbid, older. Some of my patients have cognitive dysfunction, sometimes physical dysfunction, so self-injections at home may be a problem. Cost, many of them are on government insurance and certainly cost and out of pocket with all the other medications they're on. So these are some challenges, but I'm very excited that we have at least some kind of a light at the end of the tunnel that we can probe in some of these patients. It's certainly not an easy one, but it's a journey that I think we've been waiting for because we have good drugs now for COPD, but certainly about 50% of these patients, as you know, Stephanie, despite triple therapy, which are important in addition to the treatment of COPD, they continue to exacerbate. So I think there is a big unmet need, and I look forward to seeing more and more come on board in a way that will improve the opportunity for choosing other treatments.
Absolutely. I think it's great that we have new potential therapies for some of our patients, and I know I'm excited for that as well, and hopefully our patient populations are excited too. So that we may have more to help them with. So yeah,
Yeah, Gay,
thanks.
one of the biggest need also is to find more biomarkers. Right now, we're stuck with blood EOs, and maybe the role of pheno is now emerging in COPD, but we need other biomarkers, especially for type 1, type 3 inflammation. And I think that's a big unmet need as well.
I think you are not wrong. I think we know that blood eosinophils are not, they're already imperfect in asthma, and COPD, it looks like maybe even a little bit more so, that they don't mark the type 2 inflammation as well, and certainly are lacking for the other types of inflammation. So I'm certainly hopeful that we'll be developing more over the future. But I think then, with all these potential exciting opportunities, that does kind of um, lead groups in industry and in academia to be more interested in finding some of those things that now that we have a good signal that we can help patients with some of these things.